And I think with this, we move on to the plenary for the Obesity Symposium, the ASI Obesity Week, and the Women Endocrine Week. And I invite the chairpersons for the plenary session. I request Dr. Shashank Joshi to stay on stage. And I also invite Dr. Roshni Sanghani to please come on stage.
Can we have the CV slides for the speaker, please?
So can we have our favorite Didi up here? Please put your hands together for Professor Sarita Bajaj. I call her my Didi, elder Didi. She's been a big role model for all of us, and she's really, we all know her. You know, if we have to really introduce her, she's currently, of course, the president of our Thyroid Society, but she was a very active member of our Endocrine Society of India, RSSDI. She is the founder of the South Asian Federation of Endocrine Societies. She's one of the persons, Didi, I would say that you changed the face of the Endocrine Society of India. And I think you are responsible for that. We all know her. She's just retired from Prayagraj, and she's going to really talk on a very hot topic.
I haven't retired from Prayagraj. But
you can't retire from practice, but from Prayagraj, from a medical school, I mean. And she's going to talk on a very hot topic called diabetes remission, myth or reality. And she's an endocrinologist. I'll ask Roshni to say a few words about the topic, and maybe then Didi can give her plenary talk.
So it's an honor to be here on stage with everybody that's been on the stage since morning, and I know we want to move ahead, we're running late on time. But diabetes remission, I think everybody's been kind of intermittent fasting, waiting for dinner. So hopefully whoever is thinking about what does it mean to do remission, to do fasting, you've had some real life experience today. But in all honesty, it is a very, very hot topic. It's a topic that endocrinologists need to be able to handle. It's coming up every day in our practice. And I actually contacted ma'am as well, that ma'am, you know, I want to be able to reflect back whatever you're planning to say. And yeah, it's a very, very powerful topic. So hopefully we gain something. Thank you.
Thank you. Thank you, Shashank. I call him Bhaiya and he calls me Didi. And thank you for those very kind words. Thank you, Roshni. Good, yeah, I think that's a good idea. Just requested for the chairs to be removed. Considering that we've had such an excellent session on obesity, and of course, fortunately or unfortunately, from the talk perspective, we still do not have those drugs which would actually take us towards losing that tremendous amount of weight. So I think in that context, this talk is still relevant as of now. I think there's nothing that I need to highlight in this slide, except for the fact that yes, diabetes is, as of now, a progressive disease, and if it is the body mass index or the weight gain that increases that risk, whether it is men or women. I think it is important to have the definitions clear. So remission, the word American Diabetes Association prefers the word remission to reversal, and we use the terms partial, complete, or prolonged remission depending on the A1C, the fasting blood glucose, and how long has the patient been off medication. So I think the definitions should also be pretty clear to everyone. And of course, the ADA, the guidelines for remission, for Virta Health, and the Association of British Diabetologists. So there are different categories which have been laid down by different societies. So what I now plan to do is to take you through those various steps which can help in that remission. I will talk about diet. I will address exercise, physical activity. I will address metabolic surgery and just touch a little upon drugs that have been highlighted beautifully, and then end up answering the question, or perhaps you will be able to answer it for me at the end of my talk. Is it a myth, or is it going to be translated into reality soon enough? So I started off with the Taylor twin cycle theory. So this bicycle is controlled by the handlebars, which represent chronic excess of calorie intake in the presence of pre-existing muscle insulin resistance. The raised plasma insulin levels will expedite chronic excess calorie storage from carbohydrate via de novo lipogenesis and promote liver fat storage. Then the liver takes over. In turn, insulin secretion will increase to reduce plasma glucose, and the further increased insulin levels will bring about a self-reinforcing cycle. So this excess fat will result in increased export of VLDL, triglycerides from the liver, uptake by islets, and inhibition of the meal insulin secretion. At a personal threshold, the level of the pancreatic fat imposes too great a load, and plasma glucose levels will then rise relatively rapidly. So this was about a decade back when Roy Taylor gave this theory. And in his Banting Memorial Lecture, again a decade back, he said that type 2 diabetes is a reversible condition of intra-organ fat excess to which some people respond better than others. So here too, we are going to have our non-responders. Now coming to the diet aspect, a lot has been said about low carbohydrate versus low calorie diets, dietary restriction through eating strategies, and what should be the dietary quality. So starting off with the low calorie diets, the dietary calorie restriction approaches for the remission have been either low calorie diets or very low calorie diets, again which have been discussed. And how do you follow VLCD? Again, you heard in the panel discussion right now. In the VLCD, you can use liquid formulae with 50 to 60% of the energy coming from carbohydrates, essential fatty acids to meet the daily requirements, and high biological value proteins. So as has been said, it's a healthy diet. So that is the focus here when we look at the VLCD. And you heard from Dr. Arya Sharma that he has had patients on it for even up to 3 years. So it is doable. I'm not going to go into the details of any of these, except to let you know that yes, there is evidence of low-calorie diets for remission right from 2011 onwards. Some of these studies I will be focusing on individually. So the most important one is the direct trial in the intervention group, equal number in the control group. All diabetes and blood pressure medications were withdrawn. In the control group, usual care was continued. In the intervention group, it was a very low calorie formula diet with a stepped food introduction. After 12 months, that's a year later, the weight loss was more than or equal to 15 kilograms in 24%, and in the control group, it was more than 15 in no patient out of those 149. In the intervention group, the A1C went down by 0.9%. In the control group, it went up by 0.1%. And at 2 years, in the intervention group, we have diabetes remission 36%, 3% in the control group. More than 15 kilograms, this 15 kilograms is a very important number because that's what we need to maintain that remission, was achieved in the intervention group in 11% versus 3% in the control group. So it showed that people in remission could return to normal maximal insulin secretions if they maintained their weight. So the sustenance, like Dr. Cheryl said, the sustenance part is going to be the tough one, and that is the crucial link to maintaining that subsequent remission. Again, this is the diadem study. It compared the impact of an intensive lifestyle versus routine medical care, less than 3 years of duration, a small group of 147 adults, and what they did was they stepped up the calories gradually week 10, 11, and 12, and they maintained it at week 13 for about 12 months using low-calorie meal replacement. What they defined as remission was no glucose-lowering medication, again A1C less than 6.5, and duration of more than 3 months. In the intervention group, at 1 year, there was 61% remission, vis-a-vis 12% in the control group. So the greatest weight reduction occurred between baseline and 3 months, followed by a slower but continued reduction in weight between 3 to 6 months. And after this point, it was maintained, but it was followed only for 1 year. So meal replacement with a low-calorie diet results in negative calorie balance, depletion of liver and pancreatic fat, and that is the mechanism for the reversal or remission. Now, Shashank, Bhaiya, so this is the study again, which almost a decade back, in which we've shown, and that has been discussed in the panel discussion, that we are a carb-loving country. And all across, whether it's north, south, east, west, or central India, we take in a lot of carbs. That is extremely relevant as to what I will be coming to subsequently when I tell you about the macronutrient intake study, which Dr. Mohan's group did, and in which Shashank is also there, and I'm also one of the authors. The next is the low carbohydrate diets. They primarily work on the hypothesis that when low carbohydrate diet is initiated, insulin secretion is lowered, thereby reducing the fat storage, facilitating weight loss, and improving the cardiometabolic function. Again, we have a lot of data on that as well. I'm again not going into detail. Now just comparing the low carb versus the low calorie diets. So we need to be very sure what we are talking about when we talk of the amount of carbohydrate intake. So very low carb is about 20 to 50 grams. Moderate is 130 to 230. Low is between 50 to 130. And high carb is more than 230 grams per day. Now coming to the low carb, high fat, that is the ketogenic diet. After what happens after 3 to 4 days of fasting or extremely low carb intake, our body enters ketosis and people experience brain fog or keto brain. How does it work? It increases the thermic effect of protein, targeting the satiety signals, the hormones. Ketone bodies act as appetite suppressants and long-term optimized fat oxidation. It results in lipogenesis and increased lipolysis. So the first 2 to 6 weeks are virtually the ketogenic adaptation phase, where your body is going through the adaptation of switching to relying primarily on fat versus glucose or carbohydrate. To really see the results, the diet should be followed for a minimum of 3 months. So again, we have excellent data here from the Verta Health. It was an intervention keto diet with definition of remission, and you can see the differences at 2 years between the intervention and the control group. Now, how does it translate the low carbohydrate versus the low calorie approach? Is it good for cardiovascular health? Yes, the low or the very low carb diets, they improve the indices of cardiovascular risk, but we have data up to 2 years. Even the low or the very low calorie diets, they would improve the Q-risk score up to 2 years. Do we have RCT evidence for weight loss? Significant difference from controls at 6 months, whereas in the low calorie we have difference up to 2 years. Long-term outcome data is not available for either, And as far as the remission is concerned, in a primary care series, there was a report of 46% of completers on continued metformin at an average of 2 years. And the non-randomized cohort, the report was 17.6%. RCD evidence of remission following weight management based on low carb diet is 11% at 1 year, and for the low or very low calorie diets, it's 12 months and 36% at 24 months. Then we have data from the Look Ahead trial where the diabetes remission is 11.5% in the intervention, and in the diabetes support and education, it was only 2%. Indian diabetics, this is from Dr. Uni Krishnan's data. 2 major meals, again emphasizing the high carb intake, and their results showed a significant improvement in the lipid parameters, the CRP, urine microalbumin, liver transaminase, fat, indices of insulin resistance, beta cell secretory capacity, and insulin sensitivity as well. So this is a very good signal, bright signal from this study. This is the macronutrient study that I was referring to, in which if you look at the progression from normal glucose to pre-diabetes and from pre-diabetes to frank type 2 diabetes, the amount of carbohydrate intake, the protein intake, and the fat intake is different for different categories. So this was what we tried to highlight, and this is taken from the ICMR INDIAB national study, that macronutrient recommendations in Asian Indians, and this was based on a data-driven optimization model. So you should have different eating strategies like portion control. Short-term dietary self-restraint was traditionally associated with religious practices. Intermittent fasting has been discussed. Then the 5:2 diet, which reduces intake to 500 to 700 calories for 2 days each week. So there are different types of diets which can be applied. Again, this is Dr. Shashank Joshi's data with Paramesh Jamana, the digital twin technology which enabled precision nutrition and staging of reversal. So this was a retrospective cohort study. And the way to understand the patient's unique metabolic impairment. So the individualized or the personalized approach, it uses artificial intelligence to build a digital twin model with biological data from sensors and blood work and nutritional data. There are 7 stages of diabetes reversal. Look, there were some inclusion and exclusion criteria. And you start with 0 to 6, that is those 7 stages. And eventually, there is a patient who is off all medication, anti-diabetic medication for more than 1 year, that is stage 0 with a normal A1C. So until now, diabetes reversal has most often been considered binary, with a patient having reached reversal or not. Because diabetes reversal involves the correction of complex pathophysiologies, considering reversal in stages would be ideal clinically and for motivating the patient. So you can see the percentage of patients. For example, stage 3, 19% at baseline and 32% after 90 days. So this is a significant difference. And the conclusion was that type 2 diabetes patients reached differing reversal stages during the 3 months of precision nutrition therapy, and use of reversal stages may benefit patients during therapy. So again, this is their publication in the European Heart Journal, in which the initial results from the twin precision treatment showed they are an early indicator for the translation of the scientific rationale, and TPT appears to have potential to mitigate the cardiovascular risk as well, but long-term studies are still required. So who is the right candidate? The A, B, C, D, E, F approach. A, we look at the A1C. Those who do not have markedly elevated A1C are more likely to achieve remission. Those with the body weight, greater the body weight, the greater the chance. Remember I said that 15 kilograms is important to remember. The higher the C-peptide, the better the C-peptide, higher chances for remission. Diabetes duration, greater the chance of remission with shorter duration. That is less than 6 years. Enthusiasm, motivation, and follow-up. That is extremely important. So this is, thank you for suggesting this to me. Dr. Roshni suggested that I talk a little bit about C-peptide, but that has been addressed in the ABCDEF approach as well, so I'm not going to go into details. A lot of personal factors, apart from the price promotion, ready availability of food that has already been discussed, then educate, eliminate the barriers, empower and encourage. Lifestyle modification, again, has a very, very important role in addition. Resistance training plus lean mass preservation is important. The amount of exercise that you need to do is also important for weight maintenance, weight loss, and weight loss maintenance as well. Bariatric surgery has also been discussed. I'm not going into the details of how that works. Just to tell you that yes, there is good data to show that bariatric surgery has long-term sustainability. We have data up to 20 years. This was presented in the ADA in 2022. Now, this is the summary slide now. The number one, which I haven't discussed, are the drugs. Intensive insulin therapy at early stage of type 2 diabetes. I have discussed metabolic surgery, and I have discussed very low calorie diets. So intensive insulin therapy also has a role to play. For 2 to 3 weeks in newly diagnosed diabetics, the remission has been reported for more than 2 years. And this conservation of beta cell function has also been confirmed. The newer oral anti-diabetic agents, we're not talking about the SGLT2 here, but yes, some weight loss there. These GLP-1 analogs have been beautifully discussed. This is the only slide that I have on that. So remember that monitoring is extremely important, the continuation of the follow-up. There is a drawback of rapid fall in blood glucose levels in long-standing uncontrolled hyperglycemia, risk of worsening retinopathy, which is a potential major risk factor. Biochemical remission, yes, it is possible. Weight loss of more than equal to 10% in the first few years was strongly associated with remission of about 30% at 5 years. This answer we still do not have today. That doesn't translate into better long-term outcomes for type 2 diabetes patients. I would like to summarize by saying that it is a progressive disorder. Yes, I have tried to bring you the evidence on the table that remission is feasible, looking into the different types of diet, but the maintenance, again, is the tough one, and regain or relapse is what it becomes, and you need a multidisciplinary team. So it can be achieved. So is it going to be, that's what I'm trying to say, yes, it may be soon a reality. It should not be considered as an irreversible natural course. The remission can be achieved through a personalized approach. With that, I would like to end here and invite you all to the fifth, this is the 6th year actually of this society, the 5th annual conference of the Metabolic Syndrome Pre-Diabetes PCOS Society, IPATH, that is the Indian Professional Association for Transgender Health. So this is a combo meeting that we are doing the last weekend of March. You're all invited to that. Thank you. Thank you very much.
Thank you so much, Didi. And it was very compelling, and you presented a very nice overview on the subject. You made us feel that it's not a myth anymore, it's a reality, but a lot of work in progress still. So evidence base is evolving in this direction. So thank you so much. If there are any questions, I'm sure Roshni will have some of her own insights. But this was very insightful and very well put. So if there are any questions, we'll take questions, maybe a question or two. You can see there are still people who are interested in the subject, and I know it's very, very late in the day. But Roshni, maybe a quick comment from you, and then maybe a question or two from the audience, and then we'll break for the day.
No, thanks. This was a really fantastic review all the way up to 2022, and I was super excited when the paper came out from all of you showing Indian data and showing how small changes in the carbohydrate distribution on the plate and being protein deficient in India, that is, I think, the biggest problem. Even those who consider themselves non-vegetarian, they're really not getting up to protein targets. Unfortunately, I think we blame protein for uric acid, we blame protein for gas, we blame protein for everything. So this conversation about increasing protein is where our culture somehow is very resistant. So we've got an anti-protein agenda somehow that's penetrated our culture, where everybody thinks protein is the problem. So I would say that that's one of the biggest crux of the takeaway from that lovely paper, that it gave great confidence to our public that you've got some smart people who've taken Indian data now to say we need to up the protein.
I'm not sure whether Gagan would agree with that, because I think Punjabis go crazy with doodh and dahi and don't you agree, Sandeep? Of course, the ghee as well. The ghee as well, but doodh dahi to बहुत important hai. Absolutely. They go crazy if you're not having milk or haven't had milk, or your children. It's
True. Even I've grown up with 2 glasses of cow milk a day was the routine dictum.
I'm still having my milk every day.
I went out of home. So my question, excellent talk, ma'am. So when we talk about diabetes remission or reversal, first we can debate which of the terms is actually correct. Probably remission might be more. But now there are a lot of digital apps or self-proclaimed gurus and stuff floating around the idea of diabetes reversal. While we are looking at it from a scientific perspective, this parallel stream that's going on is actually causing more damage. So how can we tackle that?
I think again I would go back and say it has to be personalized. Your patient sitting across you has to be amenable to your suggestions and to agree to disagree with what your app guru says or whatever. It's just not one size fits all. It can never be. And I agree. Whenever the patient comes to me 80, 100, 150 kilo, whatever it is, I said, please just stay there. If you just stay there, I'll give you 10 on 10. If you can do that, because the weight trajectory is 1, 5, 20, and then there's just no stopping it. I said, you just let it go. I'm sorry, there's no going back. And again, like that yo-yo Bina showed, that's the way it is. 20 up, 20 down, 40 up. I said, don't do that. You just stay there, please stay there. If you can do that, wonderful. So I think we just have to talk. There's a lot to tell your patient. I wish we had more time. So I think I should encourage all the youngsters as well.
So I think, Gagan, you make a very important point. And Didi, I think I buy what you say completely, that we need to focus. Just one small comment on what you said. I think, these apps have invaded medicine. So when I came here and I was sitting out with Aya, he was saying, today there are weight loss specialists who say, I'm a doc, I'll treat your weight, put your weight in and we'll give you a solution. And that's exactly what's happening. These all tech companies, it's like those insulin pump companies who used to hijack our patients, and the type 1 diabetics are now managed by them and their type 1 diabetics who feel empowered. So I think two caveats. If you are looking at that type of an option, it has to have a coach and a doctor, and you have to be in control of supervision of that patient, number one. Number two, Didi was very clear in her talk that it is type 2 diabetes in the first decade of its life. That's where it works, and your C-peptide point is very well taken. You have C-peptide on board, that's where it works. So I think we need to delineate that. I think the bigger challenge, Didi, I'm being a little provocative, is we have Babagiri. And we have those Babagiri ads coming out.
Absolutely.
And that's the biggest challenge which we are facing. Our actually enemies are alternatives, and they are claiming cure. You know, I mean, we saw one of the foremost experts like Arya, and all of us, none of us have succeeded in weight loss. We might have managed some people and caused a little bit of weight loss, but you know, they are just claiming that they cure. You know, so I think that's the policy, and you are at leadership. You need to really take that up, but I think remission is doable, and I think the word remission is much more compelling than reversal for two reasons. One is reversal gives you a false sense of security, and I think that's why I think the ADA mindfully said remission, because if you remit, you can relapse. So that's the connotation which was underlying that debate. And second is, I think Didi, you also made a very compelling point that despite of all this evidence, you made a very important statement which I really loved, is that there's nothing long term, and we really need to look at it long term. And some of those drugs which people like my friend Maya's company make, might have some role.
Absolutely.
I think some of these agents like semaglutides and the new age agents may have some role here to keep it long term. And there that may be a game changer. So it's work in progress. Maybe in 5 or 10 years, at least I'm happy that once medications come in, the control, Gagan, will be more with us than with the outside world. I think that's the change. And Didi, I think you are a part of that change. So thank you so much.
Thank you. Thank you so much, Bhaiya. And I think you're there too. You're following me. I think so. Or I'm following, I don't know who's following who. You know, like whenever a person comes to me and says, I've done this alternative, any one of these, then I tell him, Ayush, right? Ayurveda, Yoga, Unani, Siddhi, Homeopathy. Ye hain. There's still 4 more or 3 more to go. Go ahead, do all that, come back to me, make up your mind. I'm not in any hurry to prescribe. When you're very sure it's allopathy, don't yo-yo between that. You know, they change, come back. Of course, doctor shopping is perfectly justified, no problem. But between the pathies is where they get caught in that mesh, and it's really sad. And then add to that those apps and those gurus, and I think that's, I don't know how, there's so much more we have to compete against, isn't it? Not just ourselves.
I'd like to sort of reflect on both of those points, is that we see this challenge that sort of people are making big claims, and we need to take charge of this topic of diabetes remission. So I can say that we are working on it this way. We've built an app. I have a nutrition team, a coaching team in-house, and the long-term follow-up, so that people are not, and in fact, we've put it this way, is when you know you want to work on lifestyle change as your first form of therapy, then we should work together so that we can manage the medicines in-house. But it is very important for us to show the patient that we do know about this remission thing, so that they don't need to rely on just the Babas, that there are qualified people who can actually take care of the end-to-end experience. So yes, this is very exciting. All of us need to take this up as endocrinologists.
Thank you. Please put your hands together for Didi.
Thank you.
And I'll hand it back to the organizers.
Thank you.